Okay, so we're going to go on and introduce our speakers now. The term distinguished speaker is very appropriate for our presenters this evening. As we all know, the healthcare environment is ever changing due to advances in science related to healthcare, technology, and the changing demographics of our clients. The Affordable Care Act has been welcomed by some and shunned by others. Like the healthcare system itself, it's complex and large and may influence us depending on our type of practice and our clients. Again, this evening we have two speakers, one nurse and one dietitian, who are going to share their expertise and insights on this topic so that we can not only understand and hopefully embrace these changes, but also develop successful strategies that we can use as the ACA implementation unfolds. So let me tell you a little bit about Lisa Eaton-Wright. She is our first speaker. She's a registered and licensed dietitian nutritionist in the state of Illinois. She's the wellness coordinator at Moraine Valley Community College and also an instructor at Benedictine University. And she has founded her own private practice focused on wellness. She has synthesized her areas of passion, which include policy and nutrition. And her work has included quite a bit of leadership in our area. She's been the chair of the Legislative and Public Policy Committee for the Academy of Nutrition and Dietetics. She is the past president of the Illinois Dietetic Association, and she also was the chair for Government Affairs of the West Suburban Dietetic Association. Lisa completed a Master of Science and a Bachelor of Science in Nutrition from Benedictine University and a Bachelor of Science in Political Science from Lewis University. She spoke on this topic numerous times. She's well-versed, and last year she spoke at our annual convention to a sellout crowd in a room that seated over 1,000. So please join me in welcoming Lisa.
And it's my great pleasure to welcome Dr. Marie Lindsay. She's an advanced practice nurse and healthcare consultant. She most recently served as an associate professor at the University of St. Francis in the College of Nursing. Dr. Lindsay is well known for her expertise about the APN scope of practice. She's taught hundreds of APNs and APN students about the Illinois Nurse Practice Act and rules and regulation governing scope of practice. She's a founding member of the Illinois Society for Advanced Practice Nursing, and she currently represents ISAPN on several statewide committees, including the Illinois Alliance for Health Steering Committee, the Illinois Health Connect Provider Advisory Committee, and the Illinois Prescription Monitoring Program. Dr. Lindsay is an expert on healthcare policy and advocacy of APN practice. She's been recognized for her work and dedication to advanced practice nursing by the Illinois Nurses Association Nurse Practitioner of the Year Award in 2009, the American Academy of Nurse Practitioners State Award for Excellence in 2003 and in 2009, and ISAPN created an award in her honor, the Marie Lindsay Spirit of Advanced Practice Nursing Award. Dr. Lindsay is a well-known and sought-after speaker on healthcare policy, advocacy, and APN reimbursement. She holds a BA in English from Ohio University, an associate in applied sciences from Morton College, an MS from Rush University, and a PhD from the University of Illinois at Chicago. Please welcome Dr. Lindsay.
Well, good evening, everyone. I'm thrilled to be here, and I'm very passionate about this area. As is Marie, we've found ourselves to be kindred spirits. So we're going to talk about this alphabet soup of fitting APNs and RDNs into the ACA, ACOs, and ACEs. I do want to start off, though, with a slide that contains a quote that Marie actually requested that we put up. She was at a presentation, and she thought that this would be apropos for tonight's presentation. So I think the second part of it is the most important piece, but it's not the strongest of the species that survive, nor the most intelligent, but the one most responsive to change. And the reason that's important is because the healthcare system is transforming, and it's transforming rapidly, and it's important that all of us in practice, allied health professions, be responsive to that change. So I want to just cover quickly some of these objectives that we're going to cover tonight. Discover, we want you to discover how the Affordable Care Act is transforming healthcare, because it certainly is. Identify those models of care and the payment systems that are changing along with that transformation, and talk about those approaches that advanced practice nurses and dietitians can use to advocate for inclusion in those models of care. So with that, the road has been pretty interesting. So I want to start with talking about some of the transformation. And the goal really for me, and as we talk through, we want you to be aware of the nomenclature. There's a language, these acronyms, the ACOs, how many of you are familiar with ACOs? How about ACEs? How many of you have read the Affordable Care Act? I'm just kidding. I downloaded it on my iPad with the intention of reading it. I got through 12 pages because it is over 1,000 pages. So I also want to provide you with a disclaimer. I know Joanne sort of mentioned doing a presentation on the Affordable Care Act does not mean it's an endorsement of that piece of legislation. However, it is the law of the land. It was litigated in 2010. It went to the Supreme Court, and the Supreme Court said it's constitutional, and so consequently, it is the law of the land. So as it stands, that's how we're going to practice, and we need to figure out how we're going to fit in under that practice of care. And this subject isn't sexy, right? I mean, it's not like everybody wants to talk about the Affordable Care Act. However, I'm sure that you will impress your friends when you're out at the bar and you start talking about health care with your knowledge that you're going to leave here with today. On Jimmy Kimmel Live, back in October when I presented this in 2013, a year ago, you know, he does those things where he goes out onto the street and he asks people what they know about certain things. So they went out on the street and they said, so what do you prefer, the Affordable Care Act or Obamacare? Do you know how many people said the Affordable Care Act? Why? Oh, because it's better. And I thought, how embarrassing for them. They had no idea. So when you leave here, you will never be caught like that. You will have some information and you will know that there is no difference between the Affordable Care Act and Obamacare. And so I'm going to try to make sure, I think that the name of it is the Affordable Care Act, so I try to make sure that I reference it that way because I think Obamacare tends to be derogatory. But the goal is for you to leave here with some information so that you don't get caught in that situation. So this is sort of a quick primer, if you will, on the Affordable Care Act, what led up to it, and sort of where we are now. And then Marie's going to launch into some of the new models of care for you. So what's the triple aim? Has anybody ever heard of the triple aim? I'm going to tell you why that's important. It is the foundation for the Affordable Care Act. It is a sort of like a paradigm shift of providing quality care. And so you do want to improve the health of the population that you're serving. That's everyone's goal. Improve that experience of that individual and the access to that care, and also the cost of care. So I wanted to share another thought with you that just went out of my head when I was looking at this. But this is how the Affordable Care Act is using this as a foundation to optimize the healthcare system as we move forward. All right, so how are they going to do that? What are the problems that led to the implementation and even the thought process behind the Affordable Care Act? What were some of the issues that we were dealing with? So, of course, it's specifically designed to address these 5 things. High uninsured rates. I don't know how many of you, particularly as students, are aware of what your parents are paying or even what your co-pays are or your deductibles, but that's for somebody with insurance. But there were lots and lots of people who did not have insurance. And as a matter of fact, in 2010, 55 million people under the age of 65, and they're using that number because you're not in Medicare yet, were not insured. Healthcare spending was 17.9% of our gross domestic product. It was projected in in about 3 more years to be up to 20%. So they needed to figure out a way to capture that and reduce those costs. The sick care system, the lack of emphasis on prevention, we were only treating people who were presenting with issues and not trying to prevent those. Life expectancy in our country, out of 30, we were number 24. Yet, as a country, we were spending way more healthcare dollars in terms of trying to keep people healthy, and we weren't doing a very good job of that. And the disparities that goes across income, education level, ethnicity, and many more. So the Affordable Care Act was meant to address these 5 key issues. So this is a brief timeline, because many people don't realize, I know lots of people were aware of the Affordable Care Act sort of coming online last October, because that's when the marketplaces started opening up, open enrollment happened, and you had to go on these exchanges, which I'm going to talk about in a little bit, and purchase your coverage. So it actually started in 2010. That's when the Affordable Care Act was brought into law. And so for those of you under, say, 26, it allows you to be insured. Those were some of the provisions that were put into place long before people really realized what was happening. And I can just tell you that I followed the litigation, and every single step of the way across every year, there have been multiple lawsuits filed trying to prevent the implementation of many of these provisions. So this is just put out there to give you an idea that it's been around for a long time. More things are happening, like there's an employer mandate that was supposed to kick in already, and that's been delayed until 2015, and some of these other things won't roll out until, as you can see, 2017 and even beyond. So with the goal of transforming healthcare, you'll see this shift from left to right on the screen. So fee for service, we all know what that is. You go in and you pay for that service that you're getting, and you're going to see more of a focus on prevention. You're going to see the reduction in that limited access to care, because guess what? Now many more individuals have access to care because they were able to purchase insurance and be insured. So they're going to seek out the care that they were otherwise delaying previously. It was costly. So health IT, electronic health records, big push toward that. Lots of dollars attributed to that to sort of push that initiative forward and make sure that there's more of that health IT out there. Expanding that coverage, increasing that access, incentives for employers, incentives for employees, Medicaid expansion. That's been sort of iffy. Some states haven't even adopted it. When I presented on this a year ago, my co-presenter was a Dr. Becker out of Alabama. Alabama was not, and I don't think that they still are, they weren't going to expand Medicaid, which really, really shuts out a pretty big chunk of the population, and a chunk of the population that really needs health care coverage. And then, of course, controlling spending and reducing those duplicative expenditures. So that's how it's set out to transform healthcare. I apologize if this goes in and out. So the language of healthcare reform, and that's kind of what I want you all to become familiar with, and so does Marie. We're talking about all these acronyms. You don't have to, it's a lot of information. You don't have to walk out of here saying you know what they all are, but at least you'll be familiar with them. So I know what I was going to share with you about that triple aim. I was just in a meeting with my VP, HR director. So Moraine Valley has this huge building that we've built. It's a health, fitness, and recreation center. And we have 10,000 square feet of space in there for a health partner. And they want like health centers for employees, a health center, health clinic to come in and occupy a couple thousand square feet of space to just simply take care of employees. And so I went to a couple of pretty high-level meetings where these companies were coming in to do their presentations to sell their services to our college. And as the gentleman was presenting, he brought up the triple aim. And my VP looked at me and he's like, what's that? And I was able to tell him what that is, and he's like, how do you know that? So it was an opportunity for me to sort of like go, then I knew something else. And he wasn't aware, but he's not in the healthcare field, but it really helps to have people sitting in that room with him that are partnering with trying to make decisions about how we're going to bring things forward. So it's just an opportunity for you to know things. If you're in a room and it comes up, you don't have to ask what it is, or perhaps you can share. So these are some of the terms that you'll see, and I'm going to share with you some more on the next slide. So what's the healthcare language? There's models of care language, and there is payment language. And you'll see some of that out there. And I'm going to talk about, in a few minutes, essential health benefits, EHBs, patient-centered medical homes. How many people have heard of those? Yeah, that is a model of care that's going to be, it's pretty common, and they're expanding that all over the place. Accountable care organizations, which we asked about earlier, fee-for-service, bundled payments, and episode bundles, and patient bundles. So these are all terms that you're going to hear, see be interacting with as you move forward in your careers and in your workplaces. So I think it's important that if you want to be comfortable and confident when you're talking about that or working within that arena, you know some of this language. It really is sort of a transformation journey, so that you need to transform, what you previously knew in terms of that healthcare language into what it's evolving into. So this focus on prevention, huge, huge piece of the Affordable Care Act. Thousands and thousands, millions of dollars have been put aside for various grant projects and so forth, because they really want to push prevention and primary care. So you're going to see more of that. CMS, everybody know what CMS is, Center for Medicaid and Medicare. That is their focus. They want to drive things into a primary care model where there's somebody there overseeing that patient, but multiple health professionals participate in that model and help take care of that patient, which is where you get that episodic bundle where you're billing and different things like that. So the focus is on prevention. And CMS, so that you know, is the gold standard. They're the trendsetter. So when they make decisions about what they're going to cover, private insurance tends to follow suit. And they will then similarly cover whatever CMS is going to cover. If you haven't had the opportunity, I know you guys are getting these slides, but this U-Tunes Get Ready for Obamacare, I show it to my students at Benedictine when I was trying to educate them about the Affordable Care Act, and it's this really fun little silly sort of cartoon, but it's a really good short primer on how the Affordable Care Act works, and it'll do what I'm doing in minutes compared to the 20 minutes that we're going to do this primer here. So if you got time, I would say to watch that. So how are they going to expand coverage? What are the methods and the models? Individual mandate, what does that mean? All individuals are required to have health insurance coverage. If not, you pay penalties. Employers with 50 or greater employees, they too are required to provide health insurance. Income-based subsidies, so depending upon your income level, if you are at X percent of the poverty line, you will get some subsidies to help pay for your coverage. The marketplaces, I'm going to talk about those in a little bit. That's a big piece. And Medicaid expansion. And Medicaid expansion, like I said, is questionable across all states because Medicaid is a state-run program. So they get to decide what they want to do. And I can tell you that in Illinois has decided to expand. But I think I've heard that there are some practitioners who aren't accepting any more Medicaid patients. And so that kind of thing is happening. I do know that the Department of Insurance here in Illinois, because I met with them, they're kind of trying to stay aware of all that stuff. They actually have a very sophisticated customer complaint line, and they are keeping track of things that aren't operating the way that it's supposed to. What I will say is, the Affordable Care Act, providing national health care coverage has never been done before. And so I think there's going to be a lot of starts and stops. They're going to make some mistakes, and they're going to figure it out. They're going to perfect some models, and then they're going to let some others go. So it really is sort of up in the air, and it is changing, and you just kind of, I'm not going to say roll with it. What we have to do as professionals is roll into it, because we need to be a part of these changes that are happening in these new models of care. So the health insurance marketplace, what is that? Has anybody have you just even looked to see what it looks like? I'm going to show you the icon in the next slide for Illinois. But it really is just this clearinghouse where you can go shopping and kind of look at what the various tiers of coverage offer. And if you see at the bottom, I talk about benefit tiers. And there's bronze, silver, gold, and platinum. And so the bronze plans provide the bare minimum of what they absolutely have to have. And then the other pieces go up in terms of coverage that you get, but your cost sharing is greater, which means you're going to pay more for that insurance. But the open enrollment opened up October 1 of last year, and I'm sure that if you were all watching the news, there were some starts and stops with that, and there were some errors, and the website couldn't handle the volume. But I can tell you that even a physician that I do some consulting with, she went on there. She actually called them, and she said, within a few rings, somebody picked up the phone, and bam, 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 she had coverage. So it's just this place where you can go and purchase your health insurance. And this is the icon. You can go to this website, Get Covered Illinois, and you can shop for your health insurance right here in Illinois. And you know, everybody's getting into insurance. So it's not just the Blues. It's not just Cigna and United Healthcare. You do all know that Walmart is going to start offering health insurance coverage. So everybody is expanding into that. And if they can, you know, function well under these ACOs and use some of those incentives and show some good outcomes, they can save themselves some dollars. So that's Illinois' marketplace. Has anybody heard of these essential health benefits? When I learned about these, it's been about 18 months. I made an appointment with the insurance commissioner of the state of Illinois. I went downtown with a friend of mine because, as you can see, I called out in the dark red. Those are the areas. All of the policies that are offered have to offer these 10 categories. And if they want to switch things out in those categories, they have to be sort of equal, like lateral moves. They can't be lesser volumes of care. So everything that's up there, you're going to find, if you go on the marketplace, that your benchmark plan in every state has what's called the benchmark plan. In Illinois, I think it was Blue Advantage. And what that means is this is what we're going to model. It's a guideline for what insurance policies are going to look like. And guess what? In 2016, that goes away. They come up with a new one. So if this isn't working, and they're doing some research on that, they can figure out what's going to work. But right now, it's just a guideline. But that benchmark plan has these 10 things in it. And the red ones that I've highlighted in red show the areas where dietitians can render services. So under the ambulatory patient services and, of course, prevention and wellness. However, I can tell you that it does not, when I say it does not define provider, what that means is if you were to go look at any of the descriptions, they'll say, it could say registered dietitian, or it could say a qualified provider. So it may not even necessarily call out our profession, but it will say somebody who is qualified. And then the state gets to determine who's qualified based on your credentials. And that's where licensing is a key thing. So you're going to want to know what those are. So with that, I'm going to turn over to Marie, and she's going to talk to you about the various models of care.
So, well, what we're going to do is then I'm going to provide a little more about some definitions, and then we're going to segue into how nurse practitioners and advanced practice nurses fit in, and then Lisa's going to come back and bring it on home with the applications for the dietitians. We just thought that would be the smoothest. So, accountable care organizations, it's not the newest concept, but they like to think it is. So providers assume a collective and clinical financial responsibility for care versus fee-for-service. So when I say providers, usually what we're talking about is large organizations, like maybe Loyola. But I'm going to give you some examples there. But it's providers in sense of the institution and providers in sense of the individuals who render care. So the reimbursers, and be Medicare, it could be commercial payers, will pay providers a bonus for meeting various quality measures and shares any savings achieved by keeping people healthy, which, of course, is supposed to lower medical costs. That's the theory, right? Oh. So this I heard from someone who worked in the advocate system. But so our ACOs, just HMOs in different clothes. And the more you learn about them, the more you're inclined to say this is probably true. So these are just some that I pulled off the website of some organizations that have formed ACOs. Now, some ACOs, and if you look up ACO, you see a lot about Medicare and ACOs. ACOs, the idea is they're supposed to target a population, and they can figure out what that population is. So Medicare, of course, everyone is worried about Medicare going broke. So that's a population they like to look at. But another population, which sort of spills into Medicare, but or anyone, where you have a lot of people with chronic diseases. So, of course, the triple threat or the quadruple threat, diabetes, hypertension, cardiovascular disease, often the same people have asthma, and then congestive heart failure, which is in cardiovascular disease. So now, those who raised their hands and said they knew about ACOs, are you familiar with a particular ACO, or you just heard the concept, or because I really am interested in what you know about that. Now they're hiding under their desk. Yes, and I will repeat.
I work for Edward, so
Okay.
I'm very involved in that diabetes care. So
Okay.
we're very focused on trying to improve outcomes for patients with diabetes.
Okay. And I'm sorry, are you a dietitian or a nurse practitioner? Nurse. Nurse. Great. Anyone else? You have a
Place students and practical science nursing students. And just this week I had a preceptor tell me she can no longer take students because they're now an ACO and she don't have time.
Okay. Yeah, but I understand. But that's been a song they've been singing when productivity became a big. When they started really looking at productivity. Then it was EMR, right? How many times have we heard, oh, we're shifting to EMR, we can't take this. So, that is the excuse du jour, but, whatever it takes. I could have sworn Loyola, like, whatever the Loyola Medical Group is, I thought they were starting one, but I didn't find it. So anyway, those are just some examples. And as you can see, these are big groups. These are really, really, OSF has hospitals from Bloomington and Peoria and up in Rockford and all those other ones. So those are just some examples. But they are actually working with Blue Cross. So basically Blue Cross reached out to them and said, hey, let's put a show on in the barn, like Judy Garland and Mickey Rooney. So this is Blue Cross, but there'll be others. Other insurance companies get in the game, or they decide to work with Medicare. And one thing, physicians in theory can belong to more than one ACO. They can be a provider. And the one I think is very interesting is the independent physicians ACO. And there are a few independent physicians out there, and they have come together to form an ACO. Okay. So that's ACOs. Now we have accountable care entities, care coordination entities, ACEs and CCEs. Basically, this is language for Medicaid in Illinois. But the concepts, and Lisa mentioned the triple aim, and I go to a lot of state meetings. There's this huge, they call it, it's through the governor's office, and it's a healthcare alliance. And the stakeholders, we're talking about hundreds of stakeholders. And we're not just talking about reimbursers and providers of healthcare, but people who are concerned about housing and people concerned about the homeless and disabled and corrections. As soon as someone's released from a correctional facility, they don't have a job, usually. They need health insurance. And so there's a big concern in the state about how do we take care of those people. And surprise, surprise, a lot of these people have what? Mental health issues, right? Sometimes that's why they went to jail in the first place. So this, again, is part of Medicaid reform, which is actually almost predates the Affordable Care Act. By the way, I would like to I always call it the Affordable Care Act, and I get a little frustrated with the Obamacare because in 1965 is when Medicare and Medicaid was born under President Johnson, and I've never heard anyone call it Johnson Care. So it seems to me we could show a little respect for our current president, whether you voted for him or not. Anyway, there is, both on the federal level but a state level, there is now a requirement that at least 50% of Medicaid clients be enrolled in care coordination programs by 2015. And again, the new approach is to meeting the AAA to improve the Medicaid population. What do we know about many people on Medicaid? They tend to doctor shop. Well, first of all, many people on Medicaid move. They're in a lot of transitional housing, and that not necessarily mean homeless, but for whatever reason, they have to live in so they have different addresses. They tend to use the emergency room as their primary care provider, right? So even before the Affordable Care Act, there was a big push to try to change the behavior of many people who are on Medicaid. Now, a lot of people who are on Medicaid now are very different. They are the people who never had health insurance, can't afford the, even the bronze in the market exchange. So now we have a lot of people who are getting Medicaid for the first time who are kind of different, but just don't have health insurance. They just don't have it. Many of them work, most of them work, but they just work for places where they can't get health insurance. So the purpose of ACEs, again, there's this grave concern about fee-for-service care. And what is the issue with fee-for-service care? The feeling is that providers, rightly or wrongly, even when they're hearted in the right place, there's a great tendency to order a lot of tests or bring people sometimes back unnecessarily, just because every time you order a test or every time they come in the office, that's a claim that gets submitted to the reimburser, right? And they get money for it. And there are the issues of malpractice. I mean, that's what a lot of providers, they say that's why they do the things that they do. And I'm not rejecting that. But the United States is kind of one of the few countries that really operates that way. So there's been a real move, yes, I would say a trend to get away from fee-for-service for a long time. The patients have to navigate a complex system to find a provider. That is a problem with Medicaid. It'll still be a problem with Medicaid, but they're working on it. Oh, here's what I want to say about Medicaid. There are a lot of people who, as I said, are eligible now for Medicaid because they can't even afford the bronze plans. And you can feel sorry for them or not, but the people who work for Illinois Healthcare Family Services, that is the department where Medicaid lives, they have stacks and stacks of applications. I mean, they're really working very, very hard to get people covered, but there are only so many of them, and there are thousands of people who need coverage. The problem, of course, is providers tend to operate in silos. There are few incentives to coordinate care, take on a multidisciplinary approach to patients' holistic needs. The issue of dietitians, some of them, it doesn't even occur to them, gee, maybe I should have this patient talk to a dietitian. Or maybe they don't even know a dietitian to have the patient talk to. And so they're trying to render primary care, but many of these patients are very complex, right? They're very complex. They need behavioral health. They need help with, they might need many specialists. And so they're going to all these different people, but it's not terribly coordinated. And the idea is fee-for-service rewards quantity of services, not necessarily quantity. So the state has asked organizations, again, healthcare organizations like Loyola, Advocate is certainly a big player, Resurrection, all the big medical centers, to join in a serious movement to create new integrated models of care. So the deal is, if they want to create an ACE, they're supposed to agree to a 3-year path of a new payment structure, different from the current structure, different from fee-for-service, that will include care coordination, fees, and shared savings within the first 18 months. And then they're going to move to a prepaid capitation. And you know what capitation means? It means I have 1,000 patients who are supposed to be my patients, and I get a certain amount per month just for having them. And then what they're going to do is they're initially going to pay them some money over and above that, and that's that partial risk by month 19, and then move to a full risk capitation after 36 months. Again, this is not new. This is how HMOs work. This is how HMOs have worked for 30, 40, 50 years. Basically, what every HMO hopes for is that a lot of young, healthy people will be in the HMO, and they won't come in for services, and that the people who really need the services, the people who really need the services will be offset by these healthy people who won't need so much. Again, ACEs are provider-based organizations, again, large organizations. They get a monthly fee to care for Medicaid patients, but they still share the risk for patient outcomes. They are expected, certain benchmarks, Lisa mentioned, certain things that are expected to be done for them. Now, CCEs are similar ACEs, but with they're specific, maybe children, adults, or seniors with disabilities, complex needs, especially chronic mental illness. And by the way, there is a nurse practitioner whom I know very well who actually has a CCE to serve people with mental health needs. So, now, patient-centered medical homes. I always think this is funny because in the old days, like when I was a kid, everyone had a family doctor, right? I mean, most people had a family doctor. So it's amusing to me that we even have to talk about this thing called a medical home. So a medical home of any kind is basically, here is a provider that you go to for most of your care. That's what a medical home is. Some people don't like the word medical. They would rather we use the word health, especially nurses, but I think this is pretty much stuck. And then it's supposed to be patient-centered, which also I think is just terribly amusing. I mean, isn't that what care should be? But, of course, we all know that's not true. So it's a model or philosophy of primary care. Patients are, this is crazy, they're supposed to be treated with respect, dignity, compassion, enable strong and trusting relationships with providers and staff. It's wild. And so most healthcare reform are predicated on patients belonging to a medical home, which should be patient-centered, which is partnership among the practitioners, patients, and their families. In fact, I just connected with someone I knew in grade school, and his wife has rheumatoid arthritis, and he was asking me if I knew of other rheumatology physicians because it seemed that when the ones his wife went to, it was like, you will take these new drugs. This is what you're going to do. And I just want my little prednisone 5 milligrams a day. Can I? No. And so this idea of partnership is radical for some people. It is comprehensive. So the team, Lisa alluded to, it's a team of providers wholly accountable for the patient's physical and mental health needs. It is assumed that one single provider, whether it's a physician or otherwise, can't possibly deal with all the needs that some patients will need. It's coordinated. So you have the team, but the team actually talks to it. So getting away from those silos. Accessible. And accessible means not only geographically accessible, but that the hours work, that they have some weekend hours and they have some evening hours so that people can actually get to them and that they're committed to quality and safety. So you hear the triple aims in lots of different ways. So, as I said, it's generally acknowledged that patient-centered medical homes involve team-based care. Physician groups always assume that the team will be led by physicians. And you see the joint principles of patient-centered medical home. And those are principles that it was the AMA and the American Osteopathic Association, and I think it was the internists and, family physicians. They came up with them. But there are other definitions of patient-centered medical home, and that's what I'm trying to get across to all of you. There's more than one definition, and there's more than one definition of provider. So the other definitions, I've given you some examples. There's ARC, Agency for Healthcare Research. And then there's this thing called a Patient-Centered Primary Care Collaborative. And if you're interested, you just Google that, and they have a whole website, and that's an actual organization. And they don't talk about physician. They talk about a provider. So I say, so what is it? What do patient-centered medical homes sound like? They sound like that word holistic. Maybe we've heard of that before. And yeah, isn't that what nurses, isn't that from time immemorial? I'm probably older than most people in this room. And from day one, holistic, as I've described, that's what care was supposed to be. So he said, so it sounds like healthcare reform has finally caught up with the vision that nursing has had for decades. So yay us. And I'm sure we're going to get all the credit for that. Okay, so now we're launching into the specifics, the applications. So clearly the alphabet soup is giving us an opportunity to enhance the visibility and value of services that actually APNs have offered for decades. If some of you don't know it, who in this room knows when the first nurse practitioner program was born? Yes?
1965.
All right, he's good. Get him a gold star. Because, and I've been a nurse practitioner since 1981. And when I say I've been a nurse practitioner since 1981, people are just amazed because they thought it happened, 2 years ago, or maybe. They really do. They really do. So that just speaks how long it's taken us to become visible. So healthcare reform mimics how nursing's been conceptualized for decades, and please go out in the world and tell everybody that. Why not? The expectation is clear. It's clear, and it is clear to a lot of other people, that most of this isn't going to happen without nurses and APNs, and I was glad to hear we have a nurse out there that's involved with an ACO. I mean, you just frankly can't do it without nursing, and we're going to find out you can't do it without dietitians either. But the trick is to articulate our role of nurses and APNs, beyond the nursing community. We do a lot of talking to ourselves, and not talking, and we do a lot of publishing for ourselves instead of elsewhere. But we have some problems, and one of the problems is that APNs continue. There are a lot of barriers to practice. We have inconsistent practice authority across state lines. And some people still see us as that god-awful expression. If you ever say this and don't say it in the right context, if you ever say physician extender, I cannot be responsible for what I do. That is the grossest image. Really? But people don't always feel the way we do. So some of you know that in the state of Illinois, we have to practice with a written collaborative agreement. But now we are up to 20 states where a written collaborative agreement is not required. And that might be a surprise for some dietitians. It might be a surprise for many of the students in this room. There are many states where we have what they call plenary authority. You don't, of course we collaborate with physicians and we collaborate with dietitians and physical therapy. But you don't have to have that piece of paper, which is generally a worthless piece of paper, in order to practice. Like you, I had another thought about that, but it escaped me for the moment. I did. Here's what I wanted to say. A couple things. But so we do have to remove the barriers, and in 2015, once again, we will be introducing a bill to remove the written collaborative agreement requirement. Does not mean we won't collaborate. Doesn't mean we don't want to collaborate. Get rid of that piece of paper. But there are still people. There are nurse practitioners and midwives and even nurse anesthetists who have their own practices already in Illinois. So not everybody lets the piece of paper hold them back. But those of you, if you were on the Illinois Society for Advanced Practice Nursing meeting a couple weeks ago, one of the managed care organizations that works with Medicaid came right out and said, it's hard for us to give the status of a primary care provider to a nurse practitioner when this piece of paper is still required. Not impossible, but it makes it harder. So it actually kind of straps them a little bit too. So, and I know Lisa's going to say some of these same things. We need to frame our services as enhancing value, cost savings to healthcare that we can help reduce hospital admissions. Even now, even without the Affordable Care Act, hospitals are petrified the patients are going to come back too soon in the 30-day period. Improve health outcomes. We have to help the system meet the benchmarks. And, surprise, enhance client satisfaction. And I know that every time a patient leaves this institution, they get that thing in the mail. What is it, Press Ganey or whatever, and says, how did you like your hospitalization? We have to make a point we're not just a cost to the organization, and that's the problem with staff nurses. The only reason someone spends the night in the hospital is for nursing care. So that they're monitored by nurses, and yet nurses are considered a cost. They're not considered a revenue generator. We've been fighting that for a few decades. Okay. So, what's the answer to this question? Okay. Well, the reason I pose this question is, I want all advanced practice nurses in Illinois to belong to Illinois State Society for Advanced Practice Nursing, and then their respective national organization. And I know Lisa feels exactly the same about dietitians. And there are a lot of things that we are as an organization we can do. Unfortunately, though, when it comes to ACOs, and to a certain degree the ACEs, you all have to work within your organization. ISAPN cannot necessarily insert itself into every organization. You saw the list of names of people who already have ACOs. These are large organizations. We can't just dump ourselves and fight all those battles. We can help you fight the battles. But you're going to have to investigate what your organization is doing in terms of ACOs and in terms of ACEs and CCs for the remember, those are for the Medicaid population. So my suggestion to do that is, first of all, does Loyola have an APN group? Does anyone? Is that a yes? It's a little dark in here. And sometimes they're just APN groups. Sometimes they include the PAs in them, and that's, that works, even if some people don't really love that idea. So you need to meet with this group, and you need to keep it expanding. You need to make sure that the people who are not aware of the group become aware, and they learn to talk to each other. And then after you have your APN group and you meet on a regular basis, you have to find champions in your organization. It might be it might be your collaborating physician or not. It might be, not every physician pays attention to what's going on in his or her organization, right? Many of them, at 5 o'clock, they're in the car, they're going home to their families too. I don't like politics. Not every physician is necessarily entrenched in the system. Or find someone who's an administrator, and it probably has to be someone a little bit high up the food chain, probably, a director, close to being a vice president. And you just very politely and very discreetly say, I keep hearing about these ACOs. What's Loyola have an ACO? What are they doing about that? And you won't get the answer that day. It'll be multiple questions to multiple people to get a sense of what's going on. But what you hope is, as you're talking to people, as you're expanding this group of influential people, you hope that some of them really understand what APNs do, and that we aren't just physician extenders, which is a lot of them think that, even though they might be working with you in another, an office across the hall and not even know. So I talked about the snowball approach in both into finding other APNs and learning about ACOs. So this is a very long-term process. You have to ascertain which the healthcare reform initiatives are your organization involved in, including patient-centered medical homes. Getting this information might require a champion too. And then you have to figure out who's going to work for your cause, who's going to speak for you. At some point, we hope we can all speak for ourselves, but in the meantime, we might need someone to open the doors for us. And this must be you. All right. See what she says about dietitians.
Wait, I need the mic.
Oh, yes, you do.
I just want to comment about the in 1965 when they were talking about Medicare. Unfortunately for dietitians, our group was not represented at that table. So consequently, getting reimbursement for our services has been a challenge ever since. And so when I said I went and talked to the insurance commissioner for the state of Illinois, we wanted to know, we saw the benchmark plan, went on their website, and the benchmark plan said nutrition. So we said, what does that mean? What does that cover? Because that's a pretty broad term, right? And so, believe it or not, when she was talking about Find a Champion, a friend of mine had a physician up in Lake County, and he went with us to this meeting, and he pretty much said, I don't want to do nutrition counseling. I don't want to do that stuff. They're the qualified practitioners. Let them do it. And so at the time, it turns out they were trying to get some communication back from Blue Cross Blue Shield, and their intent by using the word nutrition was to cover diabetes, which is already covered, because under Medicare, you can get coverage for diabetes, not pre-diabetes. Like you can go there and you can have elevated blood sugars, but until you are a full-blown diabetic, don't come see us. Wait till you're the diabetic, and then we're going to cover you. Same thing with chronic kidney disease. So those were the two disease states that nutrition was going to be covering. And so what we learned is that doesn't mean that we were going to be excluded from coverage going forward under the Affordable Care Act and all of the new healthcare exchanges. What it meant was that other insurance providers could come up with other forms of coverage. And they were. There are entities out there offering insurance coverage for nutrition and for registered dietitian services. But it's been a challenge. So a couple of the buzzwords that you've heard so far have been, outcomes. I hear that all the time in my practice. They want you to demonstrate outcomes. And it's really important, particularly as dietitians, and there's this whole new system under the academy called ANDI, where they're providing a system for dietitians to track outcomes of patients to demonstrate their value that Marie alluded to. So these are some things that, do you all know what the United States Preventive Services Task Force is? Anybody? You know what? They got a lot of power, because these are a group of experts using evidence-based practice, and they're the ones that actually grade certain disease states and say whether you're going to receive payment for it or not. And they have to give it a grade of an A or a B, and when it gets below B, they won't have coverage for that. So that grade A or B is key to getting reimbursement. But what I wanted to emphasize with you is, so the annual wellness visit, and everybody know what that is? That's another service that I'm going to talk about a little bit more as we go along. But you can see that some of these, the cost sharing is going away. So it's going to it's making it easier for people to get that coverage, because they don't have to go in there, pay co-pays, and all that other stuff. It's just another opportunity to expand coverage. So for dietitians, and some of this that I'm going to talk about is going to apply to nursing. And what I want to say, I was thinking as Marie was talking, so when I was talking about those meetings where we're meeting with those health clinics, there's a whole industry out there popping up to address health care reform. And these health clinics are popping up all over the place. And guess what? They're being staffed by advanced practice nurses. So in our meeting, they brought in their nurse so that she could talk to us about what she's going to do. And they want me. I'm the wellness person. I wasn't hired to be a dietitian, but because of my skill set, they want me to partner with this clinic because I do human resources / employee wellness. So anyway, some of the things I'm going to talk about apply to the nursing profession as well as to dietitians. So what are some of the areas that are going to be covered for dietitians? So healthy diet counseling, that received a grade of B. So that's a good thing because you can do a lot of that. But what I want to emphasize is referral to other specialists, such as nutrition or dietitians. It goes back to that qualified provider. They don't always call out registered dietitian. They don't have to be the provider. It can be a qualified provider. Obesity screening for adults, and it's also for children, both receiving a grade B. And so I brought with me, because this just came out this week, or I just learned about it through an email. This is a draft. So the United States Preventive Services Task Force issued a draft recommendations to diabetes screening that concurs with the Academy's position. But the point is, it's expanding screening to asymptomatic patients who are at risk for diabetes. This is huge. This is the key to identifying all of those individuals who have prediabetes to prevent them from going into full-blown diabetes. This is key. This is huge. It opens up a lot of doors. And like I said, it is draft. It's been 3 years in the making. However, it is pretty much because they've already sort of put this out there. You can go on their website and find this there. It's pretty much a foregone conclusion that they're going to implement that. So that's a good thing in terms of it opens up roles for the nursing side, but it certainly does for the dietitian side. So what are some of those preventive services? Because as we said, prevention is a huge piece of this. So there's this no more cost sharing for medical nutrition therapy, no more copays, the annual wellness visit, and I think in our resources, I have this guide in here, and it's the ABCs of providing the annual wellness visit. It's this really nice guide, so if you don't know what it is, but it is an opportunity for registered dietitians in some of these other models of care to be able to expand their services that they offer, to demonstrate their value by conducting the annual wellness visit. Now, that might mean that you need to learn how to take a blood pressure. So what? You should learn that. You should learn how to grow that skill set, your toolbox, because you should be able to do that. And then, does anybody know, the dietetic students, where there's some action alerts out there, what the intensive behavioral therapy for obesity is? There was a huge White House petition to get dietitians to be able to independently counsel and bill to counsel Medicare patients who were obese. Well, guess what? They said, sure, you can do that in a primary care setting. And you can only bill incident to, so you have to bill under the physician's billing. And we're like, what? They don't want to do that. Doctors don't want to do that piece of it. And so we're working with the CMS to get them to reverse that, because they're saying, we need act of Congress. And we're saying, we've talked to Congress, and Congress says, no, they don't. We already have stuff in place. So we actually have a piece of legislation out there called TROA, Treat and Reduce Obesity Act. And it's actually got lots of co-sponsors. It's pretty successful. We're hoping that it passes. But it is set up to allow, and it's sponsored and co-sponsored by physicians who said, and it says, let dietitians do this service on their own. So that's sort of like the legislative fix to fix that. So that's another opportunity. And I participated in Georgia in a sort of an open mic that talked about how to implement this particular benefit, because there's some rules that you have to follow, and sell yourself to physician practices, but it's a really big opportunity. However, I have a friend, you guys, who did it. She's up in, I think it's Integra. It's up in Lake County. So effective at doing this. You get your patients, you get them in, you screen them, they have a BMI over 30. So good at getting them to lose weight, and as soon as they drop below 30, we're not covered anymore. So she's like, we're demonstrating that we're good at doing this, but you've got them below 30, so they're no longer obese. Well, what about getting them out of the overweight range even? You know what I mean? So there's some work to do on that piece of legislation and on that benefit, but look out for being so effective at what you're doing, because it really came back to bite them in the butt. So they've been working with that as they go along. All right, so what does this mean for registered dietitian? These are just some of those implications that I want to talk about. So this does the annual wellness visit, the intensive behavioral therapy. What that does is it opens up the patient pool. So you have a lot more people that you can take care of. And with more people getting coverage, they're able to have that coverage. And truly a barrier to seeing a dietitian is those services are not covered. We're not reimbursed. Doctors don't refer. It's not because they don't want to. It's because they know their patients aren't getting covered. And when she talked about patient satisfaction, a nurse in Georgia just said to me, some of them are reluctant to even tell patients that they're overweight and refer them to a dietitian, because then their patient satisfaction survey comes back bad. So it's like, really, why would you, not move that forward? So that's something to keep in mind, patient satisfaction. There's a lot of things that that you will learn as you go along in terms of billing. And I know that in some healthcare settings, you've got somebody else doing that billing. I've met with a lot of private practice dietitians who are doing their own billing. It helps to know those billing codes and just be familiar with it. It's all about knowing that language of reimbursement and payment systems and just the healthcare reform language. So I would say, Marie was talking about, you've got to be motivated, you've got to put yourself out there to be able to offer these services. I like to always, when I put up this slide, do a big shout out to Nancy Pelosi and the Women's Caucus. The reason that this breastfeeding benefit has been opened up like that is because there are women in Congress who are advocating for women and children and opening up this benefit. So, at my employer, and I'm sure here, you have to provide a place, a time, a room, an electrical outlet, privacy, all sorts of things. And they're paying for the pumps. They're paying for things that they weren't paying for before. These coverage for breastfeeding equipment rentals. And I know that there's a group of dietitians who focus on maternal and fetal health and breastfeeding. So there's lactation certification that you can get. So if that's an area that you're interested in, there's coverage for this. So this is an absolute opportunity for you to pursue that. And I would recommend doing that. And I do know that lactation specialists are looking to get licensure. They want to be licensed to do what they do. And they very well could end up tagging on to our licensure. We're trying to figure that out. But right now they're not in our licensure bill. But I know that that's something that they're trying to do. It adds some credibility to what they're doing. So what are some of those implications for being able to do that, to provide that benefit? First of all, you got to find out if you can provide and bill for that, because you want to be able to bill for it. Getting those dollars in is key. Again, consider becoming a lactation specialist, and then you need to market those services. It's all about putting it out there. And when I say market your services, I don't mean, you can go out on the open market and do it, but you also have to market it to those healthcare models that are evolving. The ACOs, the patient-centered medical homes, all of those, that's the place that we're going to have to fit into, because that's where our healthcare system is transitioning into. Worksite wellness. This is my favorite area because it is what I do. And under the Affordable Care Act, with prevention, all of these new opportunities opened up for worksite wellness. And I was telling you, they're going to bring in these clinics, which gives me an opportunity to partner with them, because they'll be actually doing patient care, and I'll be coordinating with them on the broader wellness program. So they become a component of my program, and it actually just helps me extend what I can do. So employers, like my employer, you participate in some of our wellness initiatives, and we have a biometric screening, which, by the way, the United States Preventive Services Task Force doesn't recommend the frequency of screening that we're doing, but I work with labor groups, and they don't want us to take some of that away because they think they've already sacrificed other things, and I don't recommend it, but they said, no, we want all these. So you can get all kinds of tests that you want. I had a woman requesting a PSA, and I'm like, no, you don't have a prostate, so you probably should not be doing that. But guess what? Under our benefits, they paid for it. And I'm like, and she was insisting. I'm like, no, you don't have that. So it's really interesting. So, but what happens is, if they participate in that and they participate in our wellness initiatives, they get their insurance premiums reimbursed. 2 in December, and then a third one in January if their spouse participates. So we incentivize employees as well as their spouses to participate in worksite wellness, because if you can lower your healthcare costs, it's good for everybody. It's good for everybody. So this alternative standard, so say one of our employees does the biometric screening. You have to pass, there's 3 of 5 measures, and say they only get 2 of 5. But say one of those is high blood pressure. And if they're being treated by a physician for high blood pressure, so they're taking meds, all they have to do is go to their doc, and there's a form that they fill out that's this alternative qualifying form. It's required by law because they have to be able to participate if they're being treated. They bring it in, and then they get a pass, and then they can get the insurance waivers. And you know what? In this day and age, insurance isn't cheap, and everybody likes those few bucks, particularly in December when we're waiving their waivers, their insurance premium waivers. So here's some components of wellness. And I do many of them, and I don't know if you guys are aware, but like tobacco cessation, I am now talk about expanding your skill set. I am now a freedom from smoking facilitator, so I can teach smoking cessation classes. And I did that before Senate Bill 22 went into effect. In Illinois, if you are on a college campus or university that receives public dollars, so I'm in a community college, any of our state facilities, smoking will no longer be allowed on campuses or campus vehicles July 1 of 2015. So we have an entire employee group, certain members of certain labor groups who smoke and students who smoke. So now we're going to be offering a wide range of smoking cessation programs for them. But all of these are an opportunity to, so for the dietetic interns in here, you're learning or have learned the nutrition care process. And the nutrition care process is assessment, diagnosis, intervention, monitor, evaluate. So you do that on an individual patient. But I believe that, and I know you can, and you'll agree, you can extrapolate that and take it to population health management. So you use that same process, the ADIME process, and you apply it to a population. So when all of our employees, and I usually have, we have, say, 680 benefit eligible employees, and 350 of them participate in the biometric screening. I don't get to see their data, but I get aggregate data. So I take that aggregate data and I look at it and I go, okay, we have 25 more pre-diabetics this year than we did last year. If that's the case, then I would do diabetes programming and I would bring in people to do it. Either I would conduct it or somebody else. So I look at all of that data that we collect and I base my programming around that data that we collect. So this is all stuff that you can do under worksite. I think dietitians should own this area because of that unique skill set. It's a good place to be. And then if your work sites bring in these health clinics, they're partnering with APNs. It's a beautiful mix. So I've kind of already said this. What is this? And you can. I have lots of dietitian friends who do corporate lunch and learns. So they're doing contracting things. I'm literally employed, and that's all I do is focus on employee wellness, where they go in and they do. I've had people come in. Myers employs 5 or 7 full-time registered dietitians, supermarket dietitians. They do this really cool Healthier You thing. They come into my, onto my campus, and she'll do, culinary demonstrations connected to weight management or whatever it is that I want. They've got 10 different presentations that they'll do. So there's plenty of opportunities for dietitians in the worksite wellness area, and it's growing because of the incentives. So I'm going to move through these because this is just sort of a repetition of what Marie said in terms of rethinking your value proposition. You have to sell yourself to these models of care and say, if I treat X patients, I can come in and I can have these sorts of outcomes and I can save you X dollars. That's what they want to hear. Outcomes is a big buzzword, and saving money, of course, is always a good thing. So rethinking that message, and I say to dietitians particularly, don't be afraid to expand your skill set, because there are things that, I wanted to learn how to do up blood pressure. It's something that you can offer, just like smoking cessation and being able to do finger sticks and checking that glucose, all those sorts of things. You need to be able to offer some of those services up when you're in a larger, you have to partner and collaborate with these other allied healthcare professionals. So it behooves you to expand that toolbox. You gotta be motivated. So that's what this is talking about here. Be persistent, do that teamwork, that outcomes data collection, gosh, that's key, and I wish everybody would embrace that. Even if you're doing like a worksite wait, I just talked to the academy person who developed Andy. His name is Will, and they hired him specifically to create this awesome software. And it allows you to go in. If I ran a weight loss program at work, I could just go in, enter the data, and be able to produce outcomes, poof, like that in a report. So I have this up there because I wanted to talk about a scenario of a dietitian named Mary who's been working with several large physician groups in Denver. And she's been doing that IBT benefit, the intensive behavioral therapy benefit. And she heard about patient-centered medical homes. And she wants to get into one of those practices. And so she's worked in the fee-for-service arena, but she, as you can see, she doesn't get paid if someone doesn't show. That's a horrible way to make a living, and receives little or no payment for non-office visit follow-up. So she perused the CMS Innovation Center, and I didn't address that, but let me just tell you real quick what it is. If you're some very creative entrepreneur and you come up with some really cool billing system or way you could save money, the CMS Innovation Center is looking for clever treatment and payment models that they can scale up across the country. If it's effective, they want to use it, scale it up, and send it out there to the masses. So that's what the CMS Innovation Center is. It's really clever, but they're looking for people with very clever ideas, entrepreneurs who want to, improve the healthcare system. So she looks on there, and Marie here talked about some other sites. You can go on and see who's got ACOs, who's got patient-centered medical homes. Advocate has ACOs, and I can tell you that dietitians are included in their ACOs. I don't know if Loyola has one, but if dietitians aren't in there, they should be. So she pulls together all of these marketing materials from this toolkit. And just so you know, the Academy actually created, for the benefit of its members, this lovely manual. Now, I downloaded this. It's a PDF. I sent it to Office Max and had them bind it. But it literally walks you through how to do it. It's a great, great tool. And it tells you how to reach out to physicians, what to do, that sort of thing. What you'll find is, in here, it doesn't tell you what to charge. They can't do that. That's antitrust. So she pulls together her stuff based on using this toolkit, and she goes there with this patient population. Then she proposes this proposal. So she goes into their electronic medical records. She gets that list of patients with diabetes and high blood pressure and high triglycerides and hyperlipidemia, and decides that she's going to come up with care plans for those patients and develops follow-up care plans that she can do either, at the office, at home, by phone. And then she does these group visits. She reports on the quality measures, which are those outcomes that we talked about. You want to have some standards that you're going to measure, some metrics that you want to use, and then participates. This is, again, that collaboration piece, participates in team meetings. So you could share what you're doing. So she estimates she's going to spend approximately 20 hours a week doing that. She develops a contract that reflects her hourly cost for these bundled services. And that's what you got to come up with. You have to sit down. If you really want to approach them as an independent practitioner and how you're going to fit in, what's your time worth? And what can you offer in terms of return on that investment? Can you improve their patient outcomes? And so you can ask for a yearly contract. You can ask for an hourly rate. There's all different ways that you could set that up. And then the goal is, though, if you're in an accountable care organization and they're saving money, you should be able to share in those shared savings as well. But this is a real life scenario. So as I was preparing for this presentation, I did really get this email from a dietitian. And she says, I think I'm finally ready to approach some physician groups in my area to offer my services to them. In my area, Medicare reimbursement is fairly decent. And then she talks about the reimbursement codes. It's $120 an hour. But reimbursement from private insurance companies is variable. And that's the case, with the vast majority reimbursing far less, 40 to 60. That's like half of Medicare. Can you give me some guidance for when I approach these physician groups in terms of how to work out my salary? This is the ultimate question that everybody wants to know. If I ask for a certain percentage, 60% of what the patient's insurance company pays, I stand to earn quite a bit more than if I ask for an hourly fee. So it goes back to, how do you want to be paid? However, if I have a lot of cancellations and no-shows, or if I get a lot of patients with insurances that only pay those $20, yes, we have those too, then I also stand to make a lot less money than if I ask for an hourly fee. Is there some standard way that RDs work this out with physician groups? And so she really wants, when I responded to her, she really wanted me to tell her what to pay. But there just simply was no right answer, because there isn't a single answer. So RDNs in private practice and in practice, they do all the options that she mentioned that she wants to do. Another option is to get paid X dollars per patient seen. But in the end, it comes down to her personal business decision. What does she think she's worth? And that's hard to come up with, and you're all nervous, and you don't know, and you just want somebody to tell me what to charge, but you have to figure that out. And so she needs to think about self-pay patients, because there are some patients out there who either don't have insurance or don't want to use it, or usually it's that they don't, but they're willing to pay to come and see her. So she can consider consider the self-pay patients into her income. And so when I wrote her back, she said, oh, Lisa, thanks, but I really wanted to know what to charge. And I felt bad because, we can't discuss that. It's an antitrust thing. You can't, I did send her to some private practice dietitians, and hopefully she could work that out. But the toolkits and some of the materials that the Academy provides would really be a really good resource for her to look at least for her to organize her practice. So, Marie sort of bounced off of this with on the nursing side, and it's all about, you know, demonstrating your value, supplying facts and figures. In North Carolina, Blue Cross Blue Shield sponsored a study with diabetes patients and registered dietitians showing that they saved money. It's a published study, and so we use that all the time to go out and demonstrate the efficacy of what we do. So the only thing that ever sat its way to success was a hen. So that means don't sit on your butts. I feel like I came into this profession, I've only been a dietitian for 4 years, and I came into this profession because I wanted to work on the policy side. And the reason I want to work on the policy side is because the people that are writing the policy are writing the rules that we all live by. Medicare was written by, you know, a bunch of people that it totally affects what I'm doing now for a living and my reimbursement. So I wanted to be a part of the people that are writing the rules. So I feel like my job is to motivate my fellow dietitians to get out there and advocate for themselves, because if they don't do it, nobody else is going to do it for them. So there's a bunch of resources on their website for the dietetic interns. I don't know if you've been on that site, and they just divided the site. They have a professional site and a consumer site, so things are much easier to find now. That's just some more resources, and then we have some of our sites at the end. So with that, I will conclude.